All right, welcome everybody to another Friday. It's 11 a.m. where it's almost Halloween. Almost we're getting towards the end of the year here, and we have a great lineup through the rest of the year. We're going to be taking obviously a break during Thanksgiving and during Christmas, but today we actually have a friend of the podcast, Dr. Marv Wayne, hailing from the Great Northwest up at Whatcom County EMS. And what I did was I asked Marv, Marv records all of his intubations, and he's got probably thousands of these things. So he was kind enough to pick out some great airway cases, and he's going to share them with us today. For those of you who don't know, he runs a lot of the airway courses at the national conferences. He's the one who introduced me to the UE scope back when nobody even knew what the UE scope was. So, Marv, if you want to make some further introductions, thank you, and
Sure.
take it away.
Yes. Peter, can you see my screen?
Yes.
Great. So anyway, good morning, everybody. I'm the old guy from the long away place for Florida, and where it's 39 degrees. So Peter and I have talked a lot through the years, and I've sent him a lot of my unique videos. We've been doing video recording for 18 years. We did some research with Kaleidoscope and others, and we've published several publications. So this morning we're going to do Marv's Marvelous Airway videos. I didn't exactly get the title or give the title, but I had help from others. So let's start with a question. What is the most important ligament in the body? And if you ask the orthopod, it's ACL. If you ask the surgeon, it's the ligamentum flavum. But if you ask me, it's the most important ligament in the body is the hyoepiglottic ligament. So I'm using some of these pictures with permission. Andy McCoy and I do the NMSP course, and we talk a lot about this. And here's a reference from the folks up in Hennepin and others, including Rich Levitan, who believes in epiglottoscopy and not intubation, because the key is what you do and how you control the epiglottis. And we'll talk about what is the epiglottis and what is the hyoepiglottic ligament. Well, we all know what the epiglottis is. It's the thing that closes over the glottic opening when we swallow, so our pablum doesn't drain down into our bronchi. And that wouldn't be a very good thing. So again, engage it, a little handshake here, and it opens that airway for you. Okay, so we're going to, as we go through these cases, and we're going to learn a little bit more about this ligament, we're going to see how it affects positively, and in some cases negatively, the acquisition of that airway. Okay, if we look at it on the side, you can see, where does your Mac blade want to go? It wants to go in the space above, and so that the space will then lift. You engage the ligament, and I will see if this actually will work. Sometimes it does, and sometimes it doesn't. There we go. You engage it, a little handshake, a little lift, a little further engagement, and now your glottic opening is complete. So that's the HEL, the most important ligament in the body as far as I'm concerned. All right, now I have no idea what happened there. And we'll just skip down. Okay. All right. This is what happens when you do it and you lose it. There's the epiglottis. There's the glottic opening we're trying to get to. Oh, that's beautiful. You can drive a truck in there. And now as they go to intubate, watch what frequently happens. I call it the weak wrist syndrome, because when they do that, they begin to go, that one's pretty good, but now they start letting their wrist drop. It's just a little bit. This isn't too bad. Did it really go through the cords? Well, they lifted, they made sure, but it wasn't the ideal view. So now let's look at the marvelous cases. Again, thank you, Peter, for calling it that. We had a 10-month-old. Medics responded, EMS responded, police responded. It was in an area where there's a fair amount of drug use, unfortunately. Mom smokes lots of fentanyl, and there's a question of where the toxicologic event occurred. But in any case, patient was found down. The patient was not breathing, 10-month-old. First responders, PD, they, because of the location, just gave the kid Narcan. Wasn't sure how much to give. They squirted about a half of an intranasal container in. Unfortunately, it had been quite a while, apparently, that the baby wasn't breathing effectively. BLS put an eye gel. ALS got a femoral IO. The blood sugar was 60. They weren't sure what to do, so they started dripping a little D10. We don't use D50, we use D10. There was 3 no shocks, CPR, a lot of vomitus in the airway to start with, and the iGel didn't seem to be working effectively because of that. And because of age and environment, they made the decision to transport. So let's see what happens. This is a 10-month-old. And this is Peter. You can add this? I know you don't have that many 10-month-old pediatric video intubations. So there we are. The high epiglottic ligament is beautifully engaged. The tube is slid into place. Remember, the bronchus kind of bends to the right. So you always want to corkscrew to the right. All right. Let's look at that one. Let's look at another one. 75-year-old with choking, severe respiratory distress. They were having a great deal of difficulty bagging. And they thought, well, they're having trouble bagging. iGel might not be the answer here. So they went ahead and started and intubated. This is, what is that? Anybody want to guess? Because, this unfortunately was this mass of whatever. And now they're trying to both suck it. And on the other end, they've got a McGill, and out it came. After it came out, they were able to open up the airway, again, engage the ligament. But as you will see, they start getting the tube in, and they relax the wrist. This is a common theme that we have. Now, and as they drop it, you see the ligament. They should be engaging that ligament. It should be a relationship. Well, okay, they pulled that stuff out. What is it? See, it's not something I would ever have in my life because I'm a vegetarian. These were steak. This is what was removed from the airway. So motto number 1, chew your food, before you try to swallow it. All right.
That's a lot of steak. That's a lot of steak, Marv.
Yeah.
That looks like a lot of steak. I don't know
what they were eating. Yeah, man. See, again, vegetarianism has some benefit. Although there's other things you can get in an airway. And you'll see that in a second. So have I not taught you the first time to chew? Let's see what happened on this one. This one's sort of, everybody doesn't necessarily believe me, but this is real. Now, what is this? Again, forget the dates on here. The dates have been changed for HIPAA. The timing is the only thing that's legitimate, and that's the clock timer on the UE scope. Now, the segment, we've edited, obviously, because it runs continuously. We don't allow them to turn on or off the video. So what is this? Peter, I think you know, but what's that look like?
More food?
Yep. Anything in particular?
Sushi.
Nah, we don't have good sushi where I live, but it could be. It could be. No, it could be. So, but we do have a lot of now they got to pull this out. And so they're always never sure of whether to grab it with the damn McGills, because everybody talks, just grab it with the McGills. Well, sometimes, one time it was a tumor. So they have to be a little bit careful. So now they carefully dissect this out, which they did. And because there's no way they could ventilate the patient. There was some thought about, are we going to have to crike the patient? They had the equipment available, which is basically a scalpel, a bougie, and a tube. And they finally get it out. I'm sorry it takes a little longer, but I think it's important to see how much volume of material was there. And there's still
What are they using, Marv? What are they using
at this point? They're using their fingers, suction, and McGills, all 3.
Okay.
And they have a great view, and in the tube goes. And does anybody want to guess what that is? That was a peanut butter sandwich. And it gets worse because we got them in the hospital and we bronked them. And we could get pieces of peanut butter all the way down the trachea into the right main stem. Pieces of peanut butter. He obviously didn't do well. He was pretty much too far down. And had severe anoxic brain injury. So, damn it, chew your food. This is another one. This is one of our actually earlier patients that we were videoing, and they got out, and the patient was in cardiac arrest, and They couldn't bag, again, couldn't bag. They obviously CPR was the first thing they were doing. And then they went in with the video and they see this. Aha, kind of a gelatinous material. Believe it or not, there is CPR ongoing. For some reason, you don't see a lot of motion on this patient, for whatever reason. It's kind of gelatinous looking. Anybody want to venture a guess on this one? I think the people in Whatcom County just pick up the weird shit, as they say, to put in their mouth. Well,
Caviar.
Caviar. No, we don't have caviar here. We're poor folk. We're a hot dog and, except I'm a vegetarian, we're a hot dog and Coke town. They find, again, this is where they grab with their fingers because it looked like a tumor. And then they engage the ligament. See, the ligament's engaged. You got to be able to see the epiglottis. And again, we have an engagement. And we then intubate. Well, that was grapefruit. That was a piece of grapefruit. Yeah.
Marv, can I stop you for a second?
Sure.
Because which equipment are you using that you're engaging with? Are you using a hyperangulated blade? Are you using a standard blade with a video? What's the equipment here?
Okay. So again, a disclosure. I don't get money from any of the companies I work with, Airway devices. But we've been working with UE Scope for about, the first generation, now the second generation device. The blade has a 5-degree angulation at the tip. They make a variety of blades. They have one that's an absolute standard Mac blade. They make one that has the 5-degree angulation, and that's the one that we use. We originally started working with GlideScope. The folks that Jack Pacey, who developed the GlideScope, lives across the border from me. I mean, I'm on the U.S.-Canadian Northwest border, and we've got to be good friends. And we did a lot of work with them. They took a Ranger for us and put a video recording system into it so that we could record our videos and then evaluate and such. Similar to what we're doing now. The quality is much better now. But evolution of time. And we take every one of those. They're reviewed by the supervisor, and they're done as approximately as possible. They're edited. We're using that 5-degree angulation, which is a little tricky, as you're going to see when we're going to see a bougie in a case or two, and it gets to be a mild problem with the bougie. And so you'll see, and we're kind of looking around on the market for something that might be more adjustable. Intersurgical has one that's got a little more malleability to it, if that's the right word. But that's what we're doing. So we record, edit, then we have a review chart process where the supervisor first sits down with the individual and goes through the intubation following a checklist. Then we take that, then goes to the supervising physician for the service and the medical director, being me. And then we use lots of these in CE. We've got one I didn't show. Unfortunate, it happens. And I looked at our data. It was the first one in 600 intubations where they actually could see the esophagus being intubated. I'm honest enough to admit that, and we'll tell you more. It didn't end up affecting the outcome because of the degree of injury, but it was something we have just almost never see. And they get bumped out and fallen, whatever. But this one was video. It was visualized on video, and this is what we call the ultimate learning opportunity. But I'm going to show you a case in a few minutes.
Yeah, go ahead.
I'm not going to show you that case.
The reason I asked my question is because I was wondering, using certain types of videos as far as engagement of the ligament. Obviously, the technique differs now, right? So that's really what the point of my question.
Okay,
was.
I'm sorry. I went Marv long-winded on your simple question. The answer is we're using the 5-degree angle. Now the question whether that is, there is also the straight Mac. They now make a Mac on the UE scope. They even have a hyperangulated one, which I'm not sure is available in this country. But in any case, we got used to it. We like it. We've not had problems with it.
Okay. Go ahead. Awesome.
All right.
Thank you.
Sorry about that. Now, my next motto is drive fast, drink whiskey, and take chances on a motorcycle. So this gentleman decided that he would take a turn at about 3 times the speed it should. That gives you a little facial example there. They were kind enough to get a nice look at the face, which impacted a concrete abutment. There's teeth hanging in. So this was not just a straightforward airway. You've got broken jaw, you've got swollen soft tissue, you've got the tongue, which I can't tell. I had trouble figuring out where we were. Ah, there we are. There's that magic hyoepiglottic ligament. And again, remember the ligament. Now, they had a really hard time because of the jaw displacement getting a correct position. So here's the bougie. And we're having them work on bougie more often, but this is the problem with the even slightly hyperangulated blade. The bougie wants to go posterior, even though we're in a position where it should be perfect. So they just pulled back. Always remember, when in doubt, pull back, because you're usually too deep. Too deep. Now we're where we need to be, and then the tube will slide in over the bougie. All right. Now let's look at a few burned airways. By the way, feel free to stop and ask questions, heckle, whatever you feel it's appropriate. And I'm going to do my very best. We should have time at the end, I hope, for comments or questions. All right, now for some burned airways. Whatever reason, we seem to collect these. As Peter knows, he had me do the talk. We had a New Year's Day fire a few years ago. There were 4 people in the house. Actually, there were 5. Dad and a guest were in the living room, and they broke out through the front. 2 children and mom were trapped in the bedroom, where they had both some flame exposure, but a lot of gaseous products of combustion exposure. And I happened to be paged out to the scene because I live just a few blocks away. I was able to get there pretty quickly. All that you will see were performed by pre-hospital providers. All these videos, none of them are done by ER docs who sometimes work in the field and sometimes don't. So this is, again, a 13-year-old female. This picture Peter was kind enough to pull off the internet. So this isn't HIPAA or any issue. This is just about that age child with about that degree of burn. High CO level. The question with hydroxycobalamin is a discussion of another day, but they all obviously got high flow oxygen. So this is the 13-year-old. Products of combustion in the airway. And this is what's coming out of her lungs, this massive material. So you can already see that the airway burn with sloughing of the epithelial tissues. And you're going to see it more pronounced even on the mom. So again, lots of grimace. This one was done with the child breathing. She was sedated with ketamine, and for a variety of reasons, one of which is we got 4 patients, 2 ambulances, and 2 medic units, rather, and people made a decision which ones they paralyzed and which ones they didn't, and the crew did. And a little bit grimacy, but there it goes through the cords. All right. Now this is a 10-year-old, about a 30% burn. Again, these pictures are just off the internet. There are no proprietary HIPAA issues here. And this is the 10-year-old. Now, this gets interesting. And I'm actually watching this when I'm over the shoulder. And look at the swollen airway. This is a wow. We really need to get a tube in now. We can't wait. Should we have used the bougie? Maybe. It's very easy to say all this when there isn't fire around you and people are trying to put out fire. So remember, the airway corkscrew is to the right. The bevel on the tube is a corkscrew to the right. And this is a 6 tube. And I said to the medic, I said, just gently keep pushing and gently keep turning to the right. The right way, gentle, keep going. And the guys went, there we go. And we popped through. My fear was that
if I'm not mistaken, I remember these videos. The sequence was that the earlier video on the scene, it was a smaller tube, and there was no swelling of the arytenoids. But now, this is important for everyone to know that this is why the airway the advanced airway should happen early, which you guys did, except that you
We did.
replaced the tube with a larger one, and that's the swelling that happened only 20 minutes later, right?
Correct, Peter. I was trying to, again, limit the number of videos, but yes, the really lesson on this one, maybe I should have put that for all the more reason. The real lesson on that one was the fact that we should have put a bigger tube in the first place. I was, as I said, we had 4 patients. This was a less experienced medic who never intubated 10-year-old, except at Children's in Seattle during our training. And, there's a lot of fear factor that goes on in these types of environments. So yes, the tube fell out, and then reintubation. But by the time reintubation occurred, you see what the conditions were. 2 points. Point you make very eloquently that the swelling will going to get worse. So intubate early. An eye gel, unfortunately, while it may be useful, probably won't be able to do all the things you need it to do because of the swelling that occurs beneath. Okay, this was mom. You can see her findings. She got RSI mainly because she was moving around a lot, even though her CO was relatively high. This is all up to Life Pack, by the way. And you see the sequencing, and I want you to watch the amount of material coming out of her glottic opening. This just gives you an idea. This is on scene. This is not later. All right, you can start seeing how much swelling she had. By the way, one of our fire captains literally broke through the window and carried out these people in the midst of fire and gaseous products. We were able to this one wasn't an ideal HEL engagement, but they were able to kind of sneak it over and get it in. But look at all the material coming out of the lung. This took a little longer than ideally we would have liked. So, but they got now they're beginning to engage the ligament, how important that is, and they're in. So, very important. How about drinking and smoking in bed? I know none of you live in communities where people do that because nobody smokes anymore, right? And nobody drinks anymore. Well, maybe not. So this is a gentleman who set his bed on fire without intention. And we do in delayed sequence. So a lot of the video is slightly sped up for the purposes we do the delayed sequence. So when you teach, you tell people there's carbonaceous products of combustion. But I don't just teach, I show. You can physically see these and see this early swelling. And again, HEL is beautifully engaged. The tube is placed, and your watch tube is being rotated to the right as it goes down down and through the trachea. A lot of times, if you put the tube in straight, you immediately find that you hit the back of the tracheal rings, which essentially is you're hitting the front of the heart. Okay, let's see if this one will work. There we go. Again, another smoking in bed. Again, you immediately start seeing all the carbonaceous materials. This one's really got a lot of airway clutter. And if this doesn't make again, hyoepiglottic ligament is beautifully engaged. No, I'm not just showing only the good ones. I got lots of bad ones I could show you. But this, again, proves my initial point, how important that is. Again, there's swelling, and they had to get it through. And I don't know what happened here. Let's see if this just duplicates itself, which I think it does. Hopefully. Yep, it does. So, all right. Now, this is, I call the ultimate nightmare. I had to hold this case for several years for medical legal purposes. It's a 48-year-old male seen 2 hours earlier in the ER for a sore throat. And he was worked up and they thought probably was viral. It didn't, quote unquote, look terrible. He actually ate and drank something before he left because he'd had difficulty swallowing. And I think we gave him some steroids or something. I don't remember every detail. But the family called when he got home because he was getting worse, drooling, shortness of breath. And on arrival of EMS, he was in cardiorespiratory arrest. Now what do you do? And if any of you have ever seen this before, feel free to shout out what you did and what happened. So those are the pillars, sucking your way in. And then you see some kind of a rosette looking red mass. Anybody want to guess what that is? If you're putting it in the chat, I'm not seeing the chat right now, so that's okay.
That's a big old swollen epiglottis.
Yep.
Epiglottitis.
That's epiglottitis. Huh?
Yeah. Everyone's
That's epiglottitis. Well, to make the long story short, they made 3 tries at trying to lift that, and then put the tube in. It looked like it was going in. It didn't. End tidal and everything else didn't. And they cut his neck at that point. Unfortunately, pretty much by the time they got there, he was deceased. So that's why I held the case for medical legal reasons for a while. And then it was cleared that family moved on, was no longer in the community. And so I'm now using it. But the point it makes is this must have been a very insidious disease process, because once it's there, it's no longer there. Again, just to look at that. Now, let me see if I can stop it. Whoops. We'll just go back.
You have to hover over the video. If you hover over the video with your mouse, if you hover.
Yeah, I think it should.
Yeah, then you can, there you go. You can move it along. There you go.
Yeah, I wanna see if I can stop it, which I should be.
Yeah, you could just press pause. Yeah.
All right. So I talked to an anesthesiology colleague of mine. I showed this at a talk in Israel, which both Peter's family, who he lost members, and my family live. The comment she made was, I've had one of these. She said, I took the longest straight blade I could find, shoved it all the way in as far as I could, and I lifted. And I was able to find an airway. Isn't that interesting? Now, yeah. The other thing, obviously, crank. But, all this shit going on at the same time. This was fairly far out in the county, and he was pretty deceased by the time they got there.
And also, just for everyone's knowledge, supraglottic would not work here at all either.
No, absolutely not.
Right.
And that's part of the problem, is that alternatives are limited. And I don't know, how many cricothyroidotomies, Peter, do you do in your system a year?
It's funny, I just did a CQI on one from last week. But it's probably less than, in an agency where we see about 14,000 calls, we do maybe a two or three. Okay. We had a hot dog at Costco recently, choked on a hot dog at Costco, but very few.
Yeah. Well, I went back and looked. It was like looking at the data from this esophageal innovation. I went back and looked, and we do one every 4.3 years. Partially because they are able to, for the most part, they're able to use video and to get it out. So let's finish up, because Peter gave me exactly the right amount of time. So what did we learn? A checklist is your best memory. We used the Antevi app system. We had all of our protocols and everything are integrated. And no, Peter didn't pay me anything for that. I pay him. Lead with suction. We do the salad technique, which you don't always see in these videos just because that part doesn't get picked up. Lead with suction. Video with recording, the way to go. It should be auto record, accepting that you have to edit, because medics won't turn something on, and they will always forget, quote unquote, to turn it on. The hyoepiglottic ligament is the most important ligament in the body, as far as I'm concerned, certainly for intubation. Supraglottic airway and bougie are your teddy bear when you need help. And I'm still around for teddy bears. And a systematic follow-up and review is learning, not punishment. So this is from Andy McCoy, my colleague at the University of Washington. It is child's play at times, or it's the ultimate sphincter spasm that you can experience. So thank you.
Perfect. All right. Awesome. Thank you, Marv. That was amazing. Sure, a lot of people were like, had a little elevated heart rate on some of those videos. But would love to see. We have some great experienced folks on this call. Any comments from anyone as far as There's always a question about recording. I think that we don't do it enough. I think it should be a mandatory thing. But anyone, Matt or anyone want to comment on what you guys are doing out there? And any comments? Brett, I see Brett, big Airway guy, New Jersey.
Yeah,
Go
Peter,
ahead.
I could just make one comment. Marv, that was a great presentation. Do you guys use, I'm not sure what video laryngoscope you guys do use. We use the McGrath EMS, which doesn't record. We're in the process trying to vet whether we're going to use a recording device. But when we use our hyperangulated blade, we actually marry it up with the GlideScope rigid stylet, and we find tremendous success using that hyperangulated rigid stylet. So it's in the Airway bag, and they use it pretty frequently for some of these real difficult intubations with a lot of success. And we just looked at our data over all of 22 and 23, and we're at about 91% first pass success rate
Yep.
for all comers in the out of hospital arena.
So let me answer it quickly. We use the UE scope. We've looked at everything. I get stuff sent to me that isn't even FDA approved in this country yet to look at. It is the most, and again, no money involved. It is the most cost effective. Peter, I think, uses it. I know Andy McCoy uses it in Shoreline and Fort Worth and others. It is a variety of blades. They're disposable. It's very cost effective. It's exceptionally good recording, very high fidelity recording, and relatively easy to download. That's what we use. As far as hyperangulated, we work with GlideScope for 12 years or something, and we evaluated multiple different formats for them. Their hyperangulated is a little harder to learn. I'm not sure the differential, so we're using the 5-degree excess angulation on the UE scope, and each of those have advantages and disadvantages. So, as I said, offline, I'm more than happy to talk with anybody, and I am more than happy to share. I can't give you the video because just the lawyers yell at me. But I certainly can share with you a short overview, answer questions. My email is pretty simple. It's MWAYNE, M Wayne, and I'm going to spell this at Whatcom, WHATCOM, Whatcom County, all one word. Whatcom and county are one word, .us. Or my Gmail is MAWayne, the number 2 at Gmail. So, yeah. And I'm very motivated to help others because so many have helped me through the years. And got some of my folk on here today, and I am fortunate. I work with a team.
Well, we got a big crowd here because of these videos. Let me bring in Jonathan. You came on camera. Do you want to comment? South Metro in Denver.
Yeah, no, I actually so appreciate this the topic, and the videos are absolutely fantastic. Obviously this is a hot button topic for us right now. Our correct rate is significantly higher, in part from our educational program, but it's been a good point for review. Absolutely fantastic, and I look forward to reaching out. Just absolutely love the presentation. So thanks so much.
Thanks, Jonathan. And then Matt, let's end it with Matt. Before we move over to Paul's webinar.
Hey guys, Matt Levy. Marv, thank you so much. Fantastic. We emulate almost exactly your process that you're doing here in Howard County, Maryland. 2 quick points to add without being a pitch for any particular device. The reason we went to UE Scope was because it was the only device we could find that would default to recording when we powered the scope on. So we weren't losing any videos. We, like Marv, we started with GlideScope about a decade and a half ago, went through all the iterations of them, defibrillated them, ran them over, did all those things you shouldn't do to medical devices along the way. And what we realized was we were losing airways, losing recordings of airways. The last thing is that we have built out a QA process, a CQI process, where we meet, it was every 2 weeks, it's now monthly, where we review every airway as a team, because about 80, I would say about 95, 98% of our airways are all video at this point. There's 1 or 2 random ones that aren't. So learn a lot about it. If you're not looking at your airways, you really should. You learn a lot of things about how your system is and isn't performing. So thank you.
One last comment, Peter.
Take us out. Yep, go ahead. Yep.
One last comment. It is not first pass, it's total anoxic time is the terminology I use. So 2 10-second intubation attempts is no worse nor better than 1 5-second intubation attempts. So we look at what we call a anaxic period. How long was that patient we consider not being adequately ventilated? And we're also using some technique to ventilate through the tube, or trying on a few patients as we intubate. That's been variably successful. Thank you, Peter. Thank you for all you've done to motivate others to do great things.
Thank you so much. Really appreciate you coming on again. You've been great. And just by the showing today, people really enjoyed it, by the comments. So everyone, thanks for coming on. I just put the link in the chat to pop over to the Eagles webinar. You can get another 1.5 CMEs for the physicians, for the paramedics, the EMS. I'm sorry, we don't have CEUs yet. We're working on that. But see you guys on the other side. Yeah.
Is it too late to ask one last question?
Go right ahead. Yeah, everyone's popping over, but yeah, go ahead, of course.
Let me ask you guys that use video laryngoscopes, pretty successfully. If you have 100 cases that require some sort of airway intervention, and I'll say, starting with a LMA or Supreme, whatever, up to intubation, what percent of those will be intubations versus a bridge device?
Oh, I got that number. We looked at 512. All of our BOS providers do iGel. Okay, essentially all. And I looked at that number, and we looked at 512 iGel placements. We do about 100 a year. And the number that get actually intubated of those is somewhere between 15 and 20%.
So you're saying if you do 100, if you have 100 airway cases, that 15 to 20% of those will be intubated.
Yes, but again, we use iGel for cardiac arrest mostly, obviously, because it's BOS. Okay. And some of those patients go on to be deceased in the field. Then you got to go to 100. It's a completely separate category related to trauma, asphyxia. I mean, a lot of other causes. But we do. I don't remember all of our numbers, but we've been playing around. But the bottom line is education, reevaluation, or excuse me, education, evaluation, and reevaluation. You do well what you do well.
And without the video, like Matt was saying, and like Marv, you do, the problem never gets fixed, because as Josh Kimbrell mentioned, I was on a call recently where great medic, been doing it for a long time. He pulls out a Miller on this guy at a nursing home, and we're looking at him like, what are you doing? He's like, this is what I do. So it was one of those things where like he just did what he knew that he does, and we all have those folks in our systems for sure. Can't teach an old dog new tricks, right? That's what they say.
Hey, what can I say?
But we got to keep trying.
Thanks, guys. Thank you, Peter.
All right, guys.
I'm honored.
Yeah, no, thank you. We are honored. Do me a favor, everyone. Click on this link, because I'm going to be shutting this down. Click on the link I just sent you, and then you can get over there. Thanks, Michael.